Titles for our guest speaker, Dr. Swaraj Sarkar, is joining us all the way from Sweden. Has a great time this time, and he is the true implementation guru. Before implementation sciences, I think he developed the foundations of where a lot of the frameworks have come to be. But implementation is really focused on our who we're doing it for. He's going to really talk to us about how it's developed from the ground up. So Dr. Sarkar is a Indian physician epidemiologist and also a global health diplomat who's had extensive experience on the policy level from being the director of communicability systems at WHO CRO, has had senior roles across the development sector, UNAIDS, Global Fund, the Asian Development Bank, nonprofits like CARE International, and many agencies. And he's also been at ICMR as the CG Funded Chair and has been deeply involved during the COVID pandemic and really helping on a policy level for the country. And he's currently also at the University of Gothenburg and is joining us from there in Sweden. His work has focused on strengthening public health programs, advancing community-led HIV prevention, and improving access to treatment. And he's led multiple elimination efforts throughout the South and Southeast Asia and has contributed to policy, advocacy, technical guidance, and the academics. And we're very honored to have him here to share his true implementation experience, and hopefully you can share your questions as we go through. Thank you, sir. You may start.
Hi, good afternoon. Thank you, Bhavna, and thank you, everybody. I don't think we have time to get introduced.
Dr. Sarkar, can you switch to presentation mode?
Working now?
Yes, perfect.
Okay. So, theme of my presentation is for a successful implementation research, the people with the lived experience is in the center of a success. Now, I'm one of the few old people who had the opportunity to see the HIV epidemic growing from the first case, and have also the experience of working at the national, regional, and global level, and see the metamorphosis which can happen through a good program if you put people in the center. I also had the opportunity to work in a time when there was no framework. So I want to, show you the list of the framework and their chronology, but then this, implementation research framework. But the three case studies I'll present, three stories I'll tell you, would basically show that, if you put people in the center, most of the time, framework fall in place. Framework are more for checklist and not to be of the slave of the framework. Why I'm use the word being a slave? I'll give you some experience from my Global Fund and even AIDS experience. So I go to my next slide. So these are be my 5 points. I'll first talk about the framework, the resources, and the tools matter. But inclusion of people from design of the intervention, designing service delivery, designing the problem and the bottlenecks is key. Now, we often talk about co-creation, co-design of people with the lived experience. Since I had the opportunity to work with the what we call marginalized of the marginalized people in diseases like Kala-Azar or leprosy or in HIV. Some people are socially marginalized, some people are economically marginalized. I see that, what true co-creation means is more on paper, and never practiced in real life as of today still. So I'll make some points about this. So I'll take an example of AIDS versus COVID, which both showed dramatic response. By the way, with Pranav here, I was one of the few people who predicted our epidemic before even the first case came to the right extent of epidemic. Now, so we also had the opportunity of what worked in COVID and what did not work in COVID, what worked in HIV and what did not. And then very important point is the mid-course correction. Most of the people for whom the services are delivered, they don't have any say on what is going wrong and what need to be corrected. In a funded organization, when the project fund comes, by the time report comes to the donor back, it's almost 9 months after the most of the project has been implemented or the damages has been done. There is no real-time correction. So there is no substitute of the beneficiary or the target people themselves being involved in monitoring and mid-course correction. And last, I'll be talking about what are the three major messages so that in your time, you don't go through the same mistakes which we have faced and could not correct it. If you look at the global health today, global health is in a very dangerous and very vulnerable situation. And some of us are responsible because we did not proof this situation against these vulnerabilities. So many things lie for people like yourself who are young and have your future. And hopefully you will take some messages from these lessons I have learned and like to share with you. Now, so first is the inclusion remains a key. Why implementation research or what's the purpose of implementation research? This is very important. Implementation research is not a copy textbook thing. It's about to find out, solve, and innovate for the problems. What innovation is important because you have to find out innovation. When you read CFIR, Consolidated Framework of Implementation Research, you will see that it starts with the innovation and intervention package. But in reality, it doesn't start with the innovation which people suggest or the people for which the service is designed. It doesn't start with that. There has been some modification on this. But the basic problem remains, we have to find and solve problem. But who will find out the problem? From whom you hear the problem? That's the most fundamental question. So this is a WHO framework of implementation research. That's 6 steps. I'm not going into this, but the main point I would like to say that who defines the problem and who knows the magnitude of the problem. That's the issue, and where to start and what would be the overall service delivery, how to scale up is the real issue. And therefore, my point would be that co-creation by people with lived experience. By the way, most of the time, people are with lived experience are marginalized. Either they're economically marginalized or by gender marginalized socially or geographically or for different reasons, and sometimes politically and religion-wise also these days globally all over the world. So therefore, working with them is always not easy. And the Hippocrates principle of, everybody enemy to friend, everybody has got equal right to services also more the way work for public health, because public health doesn't spare or the infection doesn't spare anybody. Therefore, co-creation of the people, we say it all the time on paper, but in reality, we often don't follow that. That's very important. I'll give you 3 examples. HIV in Bangladesh, where I had the opportunity to work with them. And I worked there between 3 years. And still today, if you look at the Bangladesh curve, Bangladesh has remained one of the zero prevalent country in general population. By zero, I don't mean zero, this, all of you. But then it also has not reached, concentrated epidemic, excepting drug user group. It has still remained after 20, or say the first case was, around 89. So 37 years, it has remained, almost negligible. How it happened? Bangladesh is 130 million population. But then, the intervention we started in a time when nobody knew that prioritize sex worker, drug user, and people transgender or gay people, male who have sex with male. Just 1% of the population. If you focus on them in Asia, you'd be able to intervene, do a big intervention. And that we did based on our best understanding of the literature. Because in India, by the time in 94, epidemic was quite high, and in some places we already reached a generalized epidemic. So, but we had the learning of how to work among the sex worker and drug user. And when my work with ICMR did not go well, and I had a very successful intervention in Manipur, and the intervention was stopped for bureaucratic and other reasons, the whole intervention. So I moved to CARE Bangladesh and then started a nationwide intervention. And within 2 years, we did an intervention. And the reason we are successful is this: we prioritize population. We put the neglected population in front of the queue, as Bill Gates say often. And we try to do intervention. We start to prioritize sex worker first among the intervention. Now, this is a AI generated. I have not purposefully used actual real life slides, but this is a brothel setting. Many of you who have worked in the brothel areas for public health reason know this. But what's the main thing is that time we tried to do. This was before 98. So most of the first implementation research framework you see that started with Paris, in 1998. So we did not have an implementation research framework. And even if we had, the famous input-output impact outcome model framework, so main thing what we did was we tried to listen to the sex worker. We knew in HIV how it spreads, what needs to be done. And we also knew that if you could collectivize the sex worker, like what has happened in India, particularly in West Bengal, the famous Sonagachi model, he could prevent HIV. But when we reached the sex workers, there was no HIV. But what we say that, we use the, PRA technique, the participatory rural appraisal technique. And Bangladesh has always been very good in qualitative techniques. We ask them on a ground, by making diagrams, like this. This is actual, simulated scenario where we ask them, what is your priority? And if you look at the CFIR framework, it starts with, inner setting, outer setting, etc., etc. But only in some framework, you start with the people themselves, And even the first framework of 1998, which was done for clinical nurses, patients were not considered. So, which was in UK. But then when we asked them, they said that HIV is not a priority. We have not heard about the disease, but we know how sexually transmitted disease in their colloquial language, they said, spread. But our problem is not to the STDs. Our problem is, I want my child to be educated. So their number one priority was child. We did a ranking. And then number two, they said, the lamp is the sign we gave for them, their own education. Most of them are illiterate. And, number three was their, their own education. And number two, the education for their children. And two things, most important thing they said. They said, if you ask us what we most important, that we are not allowed to wear sandals or the shoes when we are outside the brothel area, because police can easily identify us, and take the money from us whenever needed, or can beat us or coerce us or whatever. So that was their main problem. They want to be treated like a human being. And most of them were Muslim, but then they were buried like Hindu population in like a cremation. They were not allowed to be buried. Even after death, they did not get their human rights back. So these were the two major problems. They said, we know about condom, but unless we stop violence of the clients, the drunkenness of the client, and unless, we can put our child in a safe place without giving the child opium or Phenergan cough syrup, or put the child under the bed, we cannot have time to manage this difficult client. So the main thing they wanted is the safety of the child, education of the child, their literacy, and being respected of human being. Now, if you look at most of the framework, and I have worked, in a very high financial institutions, including US government's funded financial institutions. To shift one penny, even for creche of the children, is extremely, extremely difficult. So therefore, this thing we learned, which is called enabling environment. Enabling environment became a hallmark of a global program of prevention and treatment. Many of you may or may not know this, that today for antiretroviral treatment for HIV, the treatment cost is only $60, but almost 3 times or even less, $40, let's say, for all the 3 new drugs. But then for each patient, there are at least 3 to 4 times that amount is spent so that the patient can come in a clinic. They get a transport cost. They get a cost of staying in a, wherever in the city when they come, so that they don't lie in the street and don't go back. And the blood tests are also done free. If you go to Africa, most of the places don't have even antibiotic in the clinic, but they would have cryptosporidia antigen point of care test and HIV/TB point of care test because of HIV. Now, I'll come back to this more when I show you HIV versus COVID. HIV is the only disease. When we see Rohingya population or refugee population from Myanmar coming to Bangladesh, they are carrying their HIV card. This is the only disease, rich and poor country, and marginalized, non-marginalized people get equal treatment free of cost all over the world. And how this thing happened? Because it happened because we did not just push condom and STI tablets for the sex worker or the drug user. We tried to address violence for the sex worker. We tried to address the creche for the children of the sex worker. So that is an enabling environment. And this was a invention or innovation which was suggested by this did not appear in any of the budget line of the USAID or DFID grant those days, or ODA grants, the British grant those days. But you could easily get another NGO to work on this. But later on, HIV is the only program where these non-health budgets to intervene among the police. In CFIR, you will see the outer context management. So how to do, neutralize the police, the power structure, all of these were, packaged into enabling intervention. We have costed this. People who are interested can read some of our materials. If you go to investment frame of UNAIDS, you can see this. Now, so the major issue here is who defines the problem, for what is the major barrier for intervention. So first listen to the, people, and whether the framework suggests or doesn't suggest, or put it in a small printed line, start with this. The second one is who knows the magnitude of the problem. Then I'll give an Indian example of the Myanmar-India border example, which has come in the newspaper very highly for, Kuki and Meitei population Valley people's problem. But you will see that, I see some chat, Okay, so on the first one, since we are already delayed, I also do not want to take much of your time. These are the subjects. We can go hours and hours, and I'm almost spent 30 years of my life on this kind of diseases and program. But I'll take a break now and to take questions. Any question if you have, why the people has to define, or the beneficiaries have to define the problem for addressing a disease or intervention. Over to you for any questions. You can ask a clarifying question, you can make your comment, you can oppose any comment, and if needed, we will not go to the next or other parts. Over to you.
Thank you, sir. Before we throw it out to the audience, there were a couple of thoughts on clarifying some positions, particularly with respect to when it comes to a country of the scale and diversity of India. How does one build a community-first approach without actually breaking the whole process of problem defining? That's one. And second is, what has been, in your experience, helpful in finding out which problems matter and which problems to focus on, and how you go about them? Over.
Is it Pranab? Was it Pranab's voice? And was the question was for me?
Yes, yes. Could you hear us?
I hear little muffled. Can you crystallize sharp question?
Okay, sure, sure. What we wanted to ask you was,
Yes.
in a country of the scale and diversity of India, how do you prioritize the community's role in defining the problem? And secondly, with so many problems that are being dealt with, how do you figure out which problem matters more, how to allocate resources, and how to prioritize issues without actually breaking the entire process of problem solving? Over.
Fair enough. Other questions? Can we take some more questions and then we can answer?
Okay.
Thank you, Dr. Sarkar. Thank you, Dr. Sarkar. It was a fantastic glimpse into the chief aspects of implementation. It was such a nice example that you gave as to what we intended to implement and what were the considerations which were most important, which we had to embrace before implementing. Enabling environment. Thank you so much for that idea. I think that itself gives a huge insight into how we are supposed to have the mindset and approach to implementing anything in a new setting. One question I have is, as India is so diverse, and one community may not reflect another community. In the same way, one healthcare setting may not reflect another healthcare setting. Can it ever happen that we can create models in, say, one setting which is applicable to another? Because the people, the context, the environment are so varied in different parts. Thank you.
Okay, any more questions? So then we go for answer.
Dr. Swaroop, this is Sonali here. I hear what I heard from you fits this term I recently heard, being a good dissenter. You are questioning even the framework.
Sorry. Can you come a little bit in front of the camera, and also I can't hear you properly. Yeah,
okay,
please.
I'm here.
Yes.
Can you hear me now?
Yes, absolutely.
Okay. So I heard you that you question the frameworks. And you went into places and thinking of things which others were not really questioning. One of the objections we sometimes hear, or the reluctance to include diverse participants, is that they will hesitate to speak. वो बोलेंगे नहीं, वो बताएंगे नहीं, तो बुलाने से क्या फायदा? Right? How do you address these hesitations among the teams, the sort of technocratic teams and other people with whom you work to do the research or implement programs? Thank you.
Okay.
Any more questions from anyone?
Okay, so first thing is, sorry, one more question coming up? Oh, no, okay. So, the first question about prioritization, localization, resource allocation, that's the first question, okay, so which came from Pranav. second question is also similar issues about diversity and diversity and how to generalize an intervention in a diverse population setting or geographic setting. Also, there was a question of how to deal with the in the CFIR framework. You will see that I'm using an easy term because I'm not sure how much this framework you're already with the terms. So power structure, let's say, power structure could be a donor, power structure could be a politician, power structure could be a technocrat, power structure could be in a local area. When you work in a drug user setting or a sex worker setting, you would see the power structure could be local panwala, unless you do ethnography and local observation, you would not know who is, vandalizing or bullying the, drug user or informing the police. He would not know all of this, okay? Or a rickshaw driver who bring the clients for a sex worker could be a power structure. So I'm addressing this as a power structure question, okay? So the first point is no disease can be defeated unless you localize the disease principle in a local context. And that's the whole beauty of this framework. Anything, if you want to learn from this framework, every local area, and for scaling up purposes, you take it as a local administrative area, district, sub-district, block area. If you take this population, what is the most pressing problem there? The whole HIV program has been successful because it did not go through TV or radio to give a general message. It went into the second example, which I was coming to, was a drug user example. They are very dispersed population. Drug user, sex worker, or gay population, they are not more than 1 to 5% of the population, or less than that. So how do you find them? Now, and how do you find AIDS general principle, into this kind of population? So therefore, unless you localize your science knowledge or the global knowledge, this Bangladesh example I gave is very important because this is the only country in the whole region which had the same potential like an Indian HIV epidemic. India at one point was considered the epicenter of the global epidemic, but it is still the third or fourth highest number of HIV in the world in absolute number. So Bangladesh had the same potential, but it did not wait for the global best practices to be locally validated. Okay, so what they did was, as soon as in 1984 when the HIV was discovered, and by 89 we knew most of the first CDC's first multicenter trial came, we knew what are the interventions that work. Gay people already tried to change their behavior locally in US without any testing. So Bangladesh government, instead of waiting for best practices, immediately went into full-scale strategic planning for intervention of this program. So my first point is there is no substitute, and there, as scientists, as yourself, is very important to stand up for science and see that, whatever the technocrat says or the bureaucrats or the power structure says, see that you can implement the science. But how to implement is the art, okay? And that's not how to navigate the politics. That's a different, methodology. Evidence doesn't lead to political changes. Evidence does not lead to intervention. So how do you translate evidence into policy or advocacy? That's a different kind of thing. But my major message here is you work with the local population to see how those changes or how those science elements can be locally implemented. And that's something we call micro planning, okay? 3 elements I have picked up from AIDS response, which is successful. One is science-based response, local micro planning, and third is based on the local data, involve the local people and the power structure together. How to do that, we can give some example. But these are the 3 things I'll summarize here by saying one example. When you see the most popular global product, what are those? Coca-Cola, let's say, or Pepsi-Cola, whatever, or let's say Starbucks or McDonald's, which has globally worked out. Now in India, when Starbucks say, or McDonald's sell burger, they don't sell beef burger. Okay, they do vegetarian burger, and it's not because of the newer government or anti-beef movement, etc., etc. It was from the beginning. If you go to Thailand, you'll see that it is too spicy, compared to Caucasian palates or European or American palates. So there is a local adaptation. That's how this business is successful. And last point here is that there are certain, in the both CFIR and Paris framework, you'd see that there's a fidelity element and the adaptability element. There are a few core principles you cannot change. There is no substitute of a condom. There is no substitute of a STI. There is no substitute of treatment. But unless you adapt it to the local solution and find out those questions, how those services would be accepted by local people, there would not be any adaptation or uptake. Okay, I'll stop here. And if you think it is already, I see it's 5:30, 5:20 already. If you think we need to stop here, I'm happy to stop and get some more comments or your free opinions or this thing. Okay. Otherwise, if you want to go to the next example, I can come with another example of
Does anybody want to ask anything generally from his experience?
Sorry.
We have another question.
We have a question, Dr.
Hi, Dr. Sulu. Thank you, sir, for a very enlightening session. So I want to ask a corollary to the question that was posed earlier. So in a way, the question is also to the room. There was a variant of the question of, do we not break frameworks when we go hyperlocal, right? Some variant of that question. Am I right in interpreting that question? My question is, when the lived reality is hyperlocal, are we not normalizing epistemological violence? When we take
what violence?
Epistemological violence. So there is a framework that has been validated in one setting, and because it has been validated under fairly controlled settings in a fairly unique setting, we expect that to be the standard of implementations in completely different settings. So that, and essentially in an earlier session also that we had before you came, there was this question of, okay, so the real world implementation at scale through the health system showed much more moderate results than the pilot sessions. Is that not a problem of validity? So if you want to talk in terms of research methodology, is that an implementation problem, or is it a problem of the internal validity of the external validity of a certain method?
Okay, so now if we want to intervene or control a disease or make a public health problem, make it manageable, so there is no other choice that you have to make those. You cannot treat hypertension not giving drug. Okay, even if there is a big pressure locally, let's say for non-acceptable way of treatment or non-scientifically proven treatment, whether it's Ayurveda or hypertension or say other drugs or something. Okay, so there is no other choice other than putting a scientific treatment. Now, so therefore, whatever you do, you have to find, and that's your role. Okay, so how to find that that treatment available, acceptable, accessible, and quality. That's the whole art and science of implementation research. So it's definitely an implementation research question, and you put it very correctly. That's the central implementation research question, that whatever knowledge we have, okay, when HIV intervention started, as I say, only behavior change was the only intervention. So, and nobody has done behavior change from the health department in the past. So how do you generalize it and do it at a scale of India? So that is the whole implementation research question, and that's our role. So external validation is a must. And how do we do it is we have to find out. I'll just make a last comment here, that the example of Starbucks, what I gave, is exactly Indian example. Nobody believed, we had, problem from president of, vice president's wife that time. I'm saying that we had very powerful opposition. But starting from there, or many opposition at every level, we came out to a position where the Starbucks model I'm talking about was developed in India for HIV intervention by Gates Foundation and the government together. So on every situation, there is an answer. And my point is, most of the time, you will find the answer if you ask the local people. And that is my major message. If you get the most affected community involved, so that's where you will find the answer. The answer may not come in the textbook. And everywhere the validation and the science principle scale up is a must.
Thank you so much, Dr. Sarkar. Some of us have been WhatsApping each other in between about how glad we are to listen to you and how valuable we are finding what you're sharing. So thank you so much. Yeah. Thank you, Dr. Sarkar, for such a valuable talk. And we think we've just touched the surface of what all you have to share from your experience. And actually, some of us have been WhatsApping each other, saying how glad we are to have you with us today. And the 3 questions, I think these should hopefully remain with us as this program proceeds. And will definitely, hopefully, change some of the thinking on how to proceed with this implementation program. Yeah, thank you very much, Dr. Sarkar.
Dr. Sarkar, I know you had a few more case examples. As the sessions continue, if there's questions that we can share with you, we will do so, if that's okay with you. Did you have any final words for the audience as they're learning these methods for the first time? And I think the powerful point that you made is it's not about the frameworks and the terminologies and all the technical jargon. It's really about what solution for who we're trying to solve.
Okay, indeed, I'll try to just give, 2 minutes more talk about the next 2 examples I had, that how the solutions come from the community. My next example was a drug user community in Manipur who showed us that what would be the number of injecting drug user in a community. If I ask you or a journalist or a police, they give different answer. So how did the drug user in Manipur suggested a methodology in 89, let's say, or 90, when the first publication on qualitative anthropological study came in American Journal of Public Health in 94. And in our first publication of what is the number of drug user, how do you estimate hidden population? How do you know what is the number of sex worker in, let's say, Andaman Nicobar Islands, which are 30 islands, okay? So what is the size estimation methodology? And second example I had is in my early life of work in NICED in ICMR, We got challenged by WHO when the mother said that their children don't have 3 times stool or more, which is the definition of diarrhea. Should their child have treatment? And how the mother's knowledge we did not disrespect. We proved it bacteriologically, anthropologically, that mother's version of diarrheal definition is correct. Even if the number of stool is not more than 3, it could be a pathogenic diarrhea and they need treatment. So these are wonderful examples, and some of these are documented, some of these are not documented. So these are the example, and where comes my main message, that if you don't know the solution, look at the science as well as look at the community, and often they have the answer. WHO quietly changed its definition of diarrheal disease. You look at the diarrheal disease definition, they say 3 or more stool or mother's perception about illness of the child. And that has happened quietly without any recognition to the local workers or the scientists. Okay. So therefore, trust the people, ask problem what is, what they say. And for every situation, there is a solution at a very high level. I can guarantee you, I had the opportunity to work at, from very local level to very highest level in the world. So this is possible. Trust people, trust your own scientific judgment and your own strength. Okay, the future will be with you, because the world public health situation is not very good these days. Over.
That was very inspiring and gives a lot of hope. But I think centering it on the people and listening to the people and that hyper-locality, understanding the local situation is what will help us to help spread the what you're trying to implement to other contexts as well. Right.
Okay, thank you, everybody.
Thank you. Thank you everyone for staying longer than initially hoped. I hope this was a helpful kind of primer and taster for what we will be diving into.